Hi, everybody. Welcome to today's seminar. We really are excited to share this with you. Um, just want to make some quick announcements before we get started. So welcome to our seminar today, focused on pathways to excellence using registries to improve pediatric patient outcomes. We're joined by a host of colleagues from SHC, SMCH, and others. Very delighted that they are all able to make it today. But first, just want to make a quick announcement of our upcoming symposium next week. We hope everybody can register. We'll post that link in the chat in just a little bit. There will be a Zoom option for those who can't make it, but we do desire to have a number of people attend in person so we can have some really great face-to-face collaboration. This year's theme is on healthy mothers for healthy babies. You can see the sessions there as well as our notable speakers from outside campus that you may not be familiar with. And then just a call to action. Our Drive program is seeking faculty mentors. So you can scan the QR code. These are due by November 14th. If you are considering or are interested or have hosted Drive students in the past, we would love to have you reapply or consider applying if you have not done so. Really is a wonderful opportunity to support our undergraduate community here on campus, as well as kind of foster the next generation of those that are interested in maternal and child health. But without further ado, really delighted to introduce you to everyone who will be presenting today. So we have Ali Marshall, Evie Bass, Vivian Santillan, Cassie Bergero, Gauri Madhavan, and Govinda Shields. Sorry if I messed up anyone's names, but I did my best. But without further ado, I'll introduce you to Gauri, and we're really delighted to focus on our registry here. So I'll share my screen.
Thank you so much, Grant. Good afternoon, everybody, and happy Monday. Vivian, would you like to share your screen, please? My name is Gauri Madhavan, and I oversee the clinical registry program at the Children's Site, SMCH. On behalf of my team and I, we thank the MCHRI community, faculty members, researchers, partners, and colleagues for the invitation and an opportunity for our team to share our work and successes. We are incredibly honored and grateful for your willingness to join the seminar. The topic for today's presentation is Pathways to Excellence Using Registries to Improve Pediatric Patient Outcomes. Next slide, please. At this point, I am thrilled to announce my team and co-presenters, Ali Marshall, Cassie Bergero, Evie Bass, Govinda Shields, and Vivian Santillan. I would also like to acknowledge our leaders and executive sponsors, Dr. Grace Lee, Jessie Bargenman-Losh, Jean Chandra, and my colleague, Sijo Thomas. Next slide, please. The learning objectives for today's seminar are understanding the role of registries in pediatrics, analyzing data for quality improvement using statistical process control methodology, implementing changes based on registry insights, and exploring future directions in pediatric registries. We wanted to make sure we inspire you to learn how to build a highly reliable data collection system, reduce unnecessary manual work, analyze and act upon the data in a meaningful way. As a researcher, this might be looking at smarter approaches for you for data management, save time from manual abstraction, and further enhance collaboration with SMCH. As a valuable faculty member, this could again further enhance the value of a multidisciplinary approach, the value of stakeholder relationships, and the role of an ardent quality specialist to further reduce the gap in quality care. As a manager, we are hoping that you can leverage on this existing framework that we're going to be sharing with you shortly and registry insights. Next slide, please. So just as shared in the MCH flyer, then overview is clinical registries have become a cornerstone of advancing quality in pediatric care. By harnessing registry data, clinicians and researchers can identify trends, measure performance, and implement evidence-based improvements that directly impact patient outcomes. This seminar will explore practical strategies for leveraging registries in pediatrics with a focus on quality improvement methods and future directions in the field. Next slide, please. So I just wanted to level set a couple of definitions for us. We'll start with clinical patient registry. A patient registry is an organized system that uses observational data methods to collect uniform data, clinical or other, to evaluate specific outcomes for a population defined by a particular disease, condition, or exposure, and that serves one or more predetermined scientific, clinical, or policy purposes. Other terms which are used to refer to patient registries include clinical registries, clinical data registries, disease registries, and outcome registries. Next slide, please. Defining learning health system. Learning health system is basically a health system in which internal data and experience are systematically integrated with external evidence, and that knowledge is then put into practice. There's a continuous cycle of learning, application, feedback to generate and apply best evidence to drive discovery as a natural outgrowth of care and to facilitate innovation, quality, safety, and value. Next slide, please. For the clinical registry program, our program leadership teams are the DGIS, Technology and Digital Solutions with the School of Medicine, and myself, Gauri Madhavan. I'm extremely grateful and thankful for our executive sponsors, Dr. Grace Lee, our Chief Quality Officer, Jesse Bagerman-Losh, our Vice President for Center for Pediatric and Maternal Value, and Jean Chandra, our Director for Analytics and Clinical Effectiveness. Next slide, please. So why am I here today? Why was a program created? What does it do? I'm sure you're all curious to hear that. So participation in clinical registries represent a vital role in benchmarking data, quality improvement, regulatory, and collaborative research across clinical and quality improvement endeavors. However, clinical registries at SMCH were siloed and lacked formal oversight, leading to a lack of centralized accountability and process gaps. Gaps included a lack of compliance tracking, real-time data reporting, unnecessary manual entry data. There was an inefficient use of information services resources and time, and an unvalidated return of investment for registry participation. So we put all this into a package. Next slide, please. And we created the program in 2020. The goals of the program were a phased approach. Without getting into the details, today I just wanted us to focus on the objectives and key results, which was to apply a multidisciplinary structure to clinical data registry oversight. And as you can see, we have highlighted some words just to call to your attention, such as registry governance, to establish a centralized coordinated system. So how do we enhance the value of new and existing registries, and how do you optimize impact through accountability mechanisms? Next slide, please. And of course, we had tons of results and outcomes. I just wanted to highlight the key ones. The first one being awareness to leverage registry program, both for internal and external participation. We made it much easier to capture data for local improvement effort. We have about more than 10 registries which have been set up with REDCap API connections, and you're going to be hearing about that today. We worked together for a learning and accountability model. We actually inaugurated a learning collaborative, which is nothing but all teach, all learn. And we have hosted about 9 learning collaborators meetings. In fact, we have one planned for next month. Please let us know if you're interested. We are happy to share the calendar invite with you. And the big win is we could facilitate a partnership with our DGIS, contract administration, service line leaders, and TDS REDCap. Next slide, please. So now we're going to get into the first learning objective, which is understanding the role of registries in pediatrics. At this point, I would like to introduce my colleagues, Ali and Evie, to lead this section. Ali?
Thank you so much, Gauri. Next slide, please. So for the next few slides, I'll be discussing the craniosynostosis registry that's been built here at Stanford Children's. I wanted to give some background on the team working on the registry. So I'm the quality specialist. I work closely with Sneha Krishna from analytics, Natalie Dykesville from genetics, and Dr. Prolo from neurosurgery. The executive sponsors for this registry are Dr. Bernstein and Dr. Khosla. Slide, please. So a bit about the cohort in the registry. The population is any patient with a diagnosis of craniosynostosis since 2014, when Stanford started to use EPIC. The registry is collecting both retrospective and prospective data. Currently, there are about 1,600 patients who've been polled in the registry for cohort review, with over 700 validated with a diagnosis of craniosynostosis. Next slide, please. Thank you. The purpose and goals of the registry. So we want to monitor surgical procedures associated with craniosynostosis and assess the outcomes. The team wants to further understand genetic diagnoses associated with non-syndromic and syndromic craniosynostosis. We want to create quality improvement initiatives, as well as update and refine current protocols to deliver high-quality care and contribute to improved patient outcomes. So how does this registry lead to improvement in discovery? The craniosynostosis registry allows the team to understand our patient population and outcomes more comprehensively. We can promote and grow our program regionally and nationally through research and marketing. Craniosynostosis care plays a significant role in neurosurgical services here at Packard, which is a component actively tracked in the U.S. News and World Report. Craniosynostosis surgical care is also a substantial source of revenue for the hospital. So how did we get here? So we had data in our EHR and reports that came from our analyst. What was missing was the RN quality specialist to bring about the multidisciplinary approach. So the team hired a quality specialist, and by doing this, they were able to pilot a registry in REDCap. They were then able to secure divisional funding to set up their own internal craniosynostosis registry with help from the multidisciplinary team, including the analyst and collaborating MD leaders. Now that money is secured for the registry, data is pulling in automatically, and we don't have to worry about manual work or errors. And I'm able to contribute to QI initiatives using this data. This process is also improving channels for giving back for grants, research publications, and other hospital initiatives. In the future, we plan to do formal analyses on our data and expand to other registries, including orthognathic surgery. For the next step, I'd like to introduce my colleague Evie, who will discuss the technical portion of the data integration.
Thank you, Allie. Hi, everyone. I'm Evie. I'm with the Research Technology team under Technology and Digital Solutions, TDS. So I'm here to give a brief technical overview of the clinical data process for the registry. Now, REDCap, if you're not familiar, is an electronic data capture platform that everyone across Stanford Medicine can use. The research technology team, we are the REDCap administrators and we host the platform. An amazing feature that we have is a REDCap connection to the STAR data lake. So the STAR data lake, that stands for the Stanford Research Repository, which is data from both of the hospital's EHR systems with some filtering and some other processes done to it. So as you can see on the diagram, previously, if you wanted to put EHR data into REDCap or another source, you'd need to manually enter it. But with the STAR link, we can write queries for you to define the data that you need, and it can be automatically pulled into REDCap on a daily, weekly, or monthly basis. And I should mention a few requirements to get this data is an IRB or QI determination, and then also an approved data privacy attestation. Next slide, please. So for the craniosynostosis registry, the REDCap team collaborated with the SMCH team across the whole project, especially in refining the requested data. So the data from STAR is highly customizable and can be very precise because we work together to refine the queries and really drill down to get all of the meaningful data that we can into the registry. So what sort of data am I talking about? The data can be singleton data like demographics, or it can be repeating data like labs and medications, etc. And then as far as actually starting the process, how do we define who is in the registry? We have two different capabilities. So those MRNs could be predefined and uploaded into REDCap as the source, or like we did for the craniosynostosis registry, we can actually define a cohort query to pull in those MRNs from STAR, which Ali talked about. And next slide, please. So, the reason that all this is so important is for just one registry, we have testimonial that it saved over 700 manual hours of MD time. And we've set up, in our collaboration, more than 10 SMCH registries, which are listed here. And thank you very much. Back to Ali.
Okay, thank you, Evie. Thank you, Evie. So just to show you a little bit of our registry, we just sort of touched on the workflow from REDCap into the registry, but how I come in. So inclusion criteria into our registry is anyone with a diagnosis of craniosynostosis by ICD-10 who's been seen by neurosurgery, neurology, or plastic surgery. As the quality specialist, I validate the inclusion criteria, ensuring patients are captured accurately within the registry. Once that's done, the cohort data enters automatically via STAR data lake, which Evie just discussed. And then I do chart review and enter qualitative data. After the data capture is complete, I present the findings with the stakeholders. And so below are the domains of the registry, so you can get an idea of what data we are abstracting through the EHR integration. And as you can see, there are several domains importing data from Epic. Next slide, please. Thank you. So again, on the upper left are the domains, and this is focusing on the surgical history domain. Just as an example, you can see what data is being captured within the surgical history for the patients who've had craniosynostosis surgery. And then on the bottom left are examples of custom reports you can run through REDCap to generate data. Future goals and directions. We're focused on gaining a deeper understanding of the outcomes of from clinical treatments of common conditions. We'll be creating additional registries specifically for our craniofacial team to better track and analyze patient information. Pursuing these quality improvement and research projects is a priority. It's driving innovation and enhanced patient care. And by sharing our experiences, we'll help other divisions achieve their own quality and research. And so big wins from our team. Because of the divisional funding, we've established our first internal registry, and this initiative supports the RN quality specialist role, which is me, while integrating with our API systems. We're able to have a multidisciplinary approach to care, which is vital to continuously improving patient outcomes. The key stakeholders' involvement is essential for the successful implementation of our projects, and their expertise to our registry continues to guide us. And we're also leveraging the power of REDCap to streamline our data collection. And by reducing manual abstraction, it allows our team to dedicate greater focus on providing care to our patients. And now we're going to get into learning objective 2. I'd like to invite my colleague, Cassie, to join for this section.
Thank you, Ali and Evie. I'm Cassie Bergero. I'm going to be talking about the virtual PICU systems, or VPS. Program leadership, me, hi, quality specialist Cassie, and my partner Vivian Santillan. And then Gowrie, who you've met earlier, is our manager. We're very lucky to have an executive sponsor, Felice Sue, our medical director of the PICU, who's very engaged in our work, and Jean Chantra, of course, director of analytics. Very lucky to have her also. So what is VPS? VPS is an international multi-institutional database. It's the largest pediatric and neonatal critical care database in the world. There's over 2 million cases within VPS and over 200 hospitals participating internationally. When a patient is admitted into the PICU, we create a VPS case. So every admission to the PICU gets a VPS case. And one of the things that's very unique about VPS is it's extremely detailed. It's all manually abstracted at this point. We'll talk about potential for some integration with the medical records soon, but we abstract things like diagnosis, all active diagnosis within the patient's ICU stay, interventions like intubation. So there's a lot of detail that goes into VPS. VPS then, once we put our cases in, they provide us comparative reporting and benchmarking. And then that data set is available for research and quality improvement. We have been participating almost a decade in VPS, and we've got over 17,000 cases that have been submitted into the VPS database that are just Packard cases. So what do we do? So Vivi and I, as quality specialists, our first job is to assure that all data that gets into VPS is highly reliable and high quality. That we want to make sure everything that goes in is accurate, so that when we do quality improvement or research, we are doing it off the best data we can have. So VPS has an internal process for inter-rater reliability that happens quarterly. So all of their abstractors have to do an inter-rater reliability test quarterly. In addition to that, Vivian, who is amazing, created an internal data accuracy validation process. So before we submit any case into VPS, it goes through an analysis to look for any errors that we could have made, because like I said, it is a manual process. So all of these checks really help us make sure that the data that goes in is accurate and high quality. But then beyond that, so we make sure it's going in good, but we also want to make sure it comes out, right? We want to make sure that we have highly reliable data to inform whatever clinical queries we have. In 2024 alone, we had 19 data requests from our PICU team. So that's 19 times that our teams reached out because they needed insight into either clinical care, flow, and we were able to provide the information back to them. And then we also do analysis. So I'm going to be talking about how we use SPC format to provide data back to our PICU stakeholders that is meaningful and actionable, right? We don't want anyone spending time if it's not important to be focused on and spending time on. Next slide. So what is statistical process control? I kind of think of it of the science of statistics applied to looking at your data. It allows us to monitor and enhance the consistency and quality of the clinical processes and patient outcomes. Using SPC or Shewhart charts to display VPS data allows us, Shewhart, allows us to analyze if there's variation to a measure. Is it common cause, that's what we expect, or is it special cause, something outside of what we expected and we need to pay some attention to? And in addition, when we look at our data, we annotate it with what's going on in the hospital environment. That really helps us bring more meaning to those data points so we can understand impacts to our data. So next slide. So this is how we used to show our data to our PICU leadership team. This is ICU discharge per quarter, or volume. You can think of it as volume. We used to provide it to our team members in a 1-year snapshot. We do have benchmarking here, which is helpful, but we really can't see the big picture. We only are seeing 1 year. And as anyone in hospital knows, we are variable even just by time of year, right? So the PICU is going to be usually the busiest in winter when respiratory season is going, and maybe the slowest in summer. So by only looking at 1 year of data, I can't understand the fluctuations and what's normal and what's not. I can't reliably observe trends. Next slide. So this is that same data that's now in SPC format. So first of all, we've extended the timeline where you can see the data. We've put in statistical process control limits that show us upper control and lower control. So what do we expect? We expect our data points to be in those control spots. And if they're not, that tells us that there's something to look at. And you can see I've talked about annotation. There's two places I want you to look at. One is March 2020. You can see our volume just went so low, way below what we would expect. Well, what happened? We all sheltered in place, right? And so by annotating it, as I look at my volume over time, it makes sense why we had this precipitous drop. Then if you look at the winter of 2022, you can see we have some really high data points. We had a huge respiratory surge. It was outside of what we would expect, right? We're coming out of shelter in place, kids are going back to school, everybody's getting all the germs that they weren't getting before, and we had really high PICU volume. That tells us that something happened special, and it's a place to to pay attention to. And then as we look at our data over time, when we have enough data points that show that we've had shifting, we can then move our data and show where we're at in terms of our current average. So if you look at 2024, we're showing that we're about at 200 discharges from the PICU every month. And this data really provides meaningful insight to our PICU leadership so they can look at the data over time and take action where necessary. Next slide. So our big wins, I think one of the wins is us. Vivi and I really understand Packard. We understand the PICU. We understand our culture. That helps us identify what are the best indicators to look at, where we need to focus, how we can inform our clinical leaders. Being here at Packard really helps that. We have a highly engaged PICU leadership. Like I said, 19 times in 2024, we got reach outs for data. That makes us so happy, right? We put in all this time to make sure the data is good and accurate and high quality. We want it to be used. We don't want it to just sit there in the little database, right? We're in the process of looking at some Epic integration with VPS so that we don't have to do as many manual fields. So you heard earlier the REDCap process. This is one within VPS, but it would help with the efficiency of our manual abstraction. And then one of the things we're most excited about is using our deep quality data set to look at and understand health equity and ultimately improve the services we provide to our patients through our PICU. So our next learning objective will be implementing changes based on registry insights, and Govinda Shields will be talking to you about that. Thank you.
Thank you, Cassie. I am going to talk about the National Surgical Quality Improvement Program, Pediatric, so NSQIP PEDS for short. Our program leadership is Dr. Laura Prolo. She is our surgeon champion. I am the quality specialist and surgical clinical reviewer. Gauri is our registry manager. Our executive sponsors are Dr. Balakrishnan, he is our surgeon in chief, and Jean Chandra is our director of analytics and clinical effectiveness. Next slide, please. An overview of the NSQIP program. It is an ACS NSQIP Pediatric is a data-driven, risk-adjusted, outcome-based program to measure and improve the quality of surgical care. Participation is an essential part of the children's surgery verification program. The benefits of participation include identifying quality improvement targets, improving patient care outcomes, decreasing institutional health costs, and there are 155 participating sites, 7 of them being international. Next slide. The process for the NSQIP program is the hospital abstracts the data, so that would be myself. The data is analyzed by the ACS NSQIP Pediatric program. The data is reported back to the hospital, and it's reported back in risk-adjusted semi-annual report. That report is reported back to the hospital in their QAPIs. The hospital acts on the data, and then the hospital monitors intervention with the data. One of the requirements of the NSQIP program is that we notify providers of the post-op occurrences. And the traditional way to do this is to send emails of the occurrence to providers and hope for a response back. And I'm going to talk about how we improve that process. So we developed, the NSQIP team developed a database and registry for data collection that utilizes customizable forms that are tailored to the operational definition of occurrences. We then set up some data alerts in the form of survey notifications employing REDCap's automated workflows to send the surgeons a survey, and it also sends follow-ups to reduce the likelihood of missed and delayed notifications. The workflow also triggers the children's surgery verification team to review the cases if they are flagged by the NSQIP team. So myself and Dr. Prolo go over the occurrences on a monthly basis. And if we feel like it's something that could be used for a quality improvement project, we send a notification to the to the children's surgery verification team. We also use REDCap for a data request, kind of like VPS does, and in the form of a survey to enhance collaboration with surgical teams in the organization. And the steps that are starred on this slide are ones that have reduced manual work. So you see it's a lot of manual work that was reduced. The next slide I'm going to be talking about is, the next slide is just going to be examples of the notifications. So on the left is the demographics for the procedure. So you see the information that I enter. That then sends a survey to the surgeon, which is on the right. This would obviously be filled out with the occurrence details. They have a chance to respond if they feel like there's something they need to improve or not. They can respond. And then next slide. That sends a email notification to myself that has been filled out, which is so that it doesn't get missed. And then on a monthly basis, on the right-hand side, you'll see Dr. Prolo and I go over these to decide if it's something that needs to be further investigated into a quality improvement project, or if it's just like a one-off. Next slide. Our big wins. The surgical clinical reviewer, myself, collaborating with the CSV program to offer best practice, partnership with the QAPIs to present risk-adjusted data, provide data for QI projects and improve outcomes, real-time monitoring reporting, and collaboration with various teams to share the data for QI projects and research. Next slide. For our final learning objective, it's exploring the future direction in pediatric registries. I'm going to bring it back to Gowri.
Thank you, Govinda. So I know we looked at 3 learning objectives, and thank you, Ali and Evie, Cassie and Vivian and Govinda. So for each of those learning objectives, for the first one, understanding the role of registry in pediatrics, analyzing data for quality improvement using SPC and implementing changes based on registry insight. We shared with you of how we are actually using the registries that my nurses, RN quality specialists are using, and what is the value that we have put out there for the hospital and the ROI. And now you have seen how they have displayed their data, how is it being used effectively, and so much more that they do. So now if you get to the 4th learning objectives of exploring, so of course there's a curiosity to say, this is great, so how do you plan, what are your future directions in pediatric registries? Next slide, please. So building on the successes of our clinical registry program, we are now excited to apply our insights, and learnings and successes to develop a comprehensive framework designed to enhance both quality and non-research programs. Because right now it's a typical IHI model, right? You want to start small, you want to make sure you have a success, and then what do you learn from that? So we now applied it for clinical registry. We know that we could do this successfully. But now we have a broader umbrella. We want to now see how do we apply this framework for quality and non-research programs and projects. So that's kind of what we want to do. So please stay tuned for that. We really appreciate your trust and hope we have excited you enough to have us back in a future seminar where we can share more about how we are doing this. And I really want to end today with a quote that is so tuned to our learning objectives on systems adaptability and improvement. It goes by Charles Darwin. It's not the strongest of the species that survives, not the most intelligent, but the one most responsive to change. And on a lighter note, we all talk about sequels, what's coming next. You might be a Harry Potter fan out there. You might be a Wicked fan. I know that's coming out in November. You might be Lord of the Rings fan. And for those of us who are on Netflix, I think Diplomat is coming up pretty good now. The sequels have always been exciting, right? I don't think we've ever got bored or they've ever disappointed us, at least speaking for myself. So we hope our work will also not disappoint you. And, we do want to stay connected with you all and, this very nice community who's so willing to, listen to us today. So with that, I would love to open it up for questions and answers for all of us. Thank you. I think we can pull down the screens, Vivian, and we can we'll take it back for any Q&A, please. Thank you. So maybe I can just give a thought, for, well, we already see a question there. Okay. This is expensive work, yes. What funding mechanisms exist for faculty? That's a great question, Dr. Bhargava. So there are a couple of options. One is if your work is research related, then obviously that sits with the School of Medicine and your faculty funding. So, we'll then request you to go through your university funding, divisional funding. And again, REDCap sits with School of Medicine and TDS. So obviously, they are your customers, and, they are more than happy to talk to you regarding, what can be done if it comes to research. Now, if you have to think in terms of quality, then, we request that you come to us with a proposal. We request that, there is some pre-work done on your current state. What is it that you're trying to do? And, talk to us, meaning, our group, to understand what's your current system for data capture. What is it that you want to accomplish? And then what is the initiative that you're trying to support? So is it a service line or is it a project initiative? And the registry work group is more than happy to give some directions on where that might sit. So it again depends on the kind of the work stream that you're focusing on. So again, if it's research, it goes back to the university funding. But for hospital funding, we do have a process, and we try and get you through the application process for that. Who is the contact person to initiate this conversation? I would say, let's start with me. I'm happy to, get that conversation started. And then if it's research, again, we will request you to directly, reach out to REDCap if that's what you want. If your main goal is to get your data from EHR and get it into REDCap as a database, I think, Evie's here. Evie, do you want to just share, how to contact and, whom they can contact in your team? You'd appreciate that. You can directly contact the TDS team, but if it's something related to the hospital, you're more than welcome to contact me, and I will share my email in the chat, which is also there in the flyer.
And I just want to jump in really quickly, Dr. Bhargava. I think one of the things that Gauri has brought to this program is actually building a program, right? So we have a lot of registries. We had no process. Before Gauri wouldn't have been able to answer your question. Right now, Gauri has really developed a process where she can guide you through the process of trying to identify funding, contracting. I just can't express enough how Gauri has taken something that was very small and kind of distributed throughout the organization, brought it together with a clear structure and framework, and the outcome of making sure that if we're putting data in, we're getting it out and we're using it for the organization. So personally, I feel very, very lucky to have Gauri directing this work. I think without her, we would still be in the dark ages for registries.
Oh, thank you all. I appreciate that.
Hi, this is Sushma Reddy from cardiology. Thank you for your presentations. I'm wondering how we move away from manual data entry. If you take just cardiology, and I'm sure this is across all divisions, we are entering data into multiple registries, and most of the time, over 50% of that data is the same data.
Mm-hmm.
How do we get away from this manual data entry?
Sure, I'm happy to take the first stab, and I'll also invite my colleagues to chime in. So the first thing, Dr. Reddy, is I would start with building your metrics. So what exactly, I mean, you have to think of it like a phased approach. Yes, we do want to share data outside of Packet for registry A, B, C, right? I think the first, I would take a couple of steps back. I would say, let's firm up what you're doing inside. So within your heart center, if you can kind of come up with your quality metrics to say, these are my quality metrics, and this is my metric definition. So this is my numerator. This is my denominator. In your current state, where is the data coming from? Is it coming from a workbench report? Or are you getting a report from an analyst? In other words, they call it a BI report. So it doesn't matter. So I would say, please start there, build your metric definition. And then where does this metric get reported? Is it your copy, which I'm sure it is? So then you have a repository of your metrics. And then how often are you reporting this metric? So, is it on a monthly basis? Is it on a quarterly basis? So once you firm that up, then that's kind of going to be your Bible to then understand what do you need to submit in your external registries. It could be 1, it could be 2, it could be 3. And yes, this is not the first time we are hearing this, information. So then I would say, take your external registries and do a crosswalk of what you have done for your internal. because your external registries will just need the data field, right? But your internal one, you're actually building up as your QI metrics. So then you need to do a crosswalk. I am sure for maybe 5 elements is something you're going to be submitting the same thing for maybe 1 registry, 2nd registry, 3rd registry. So you basically have to build a master sheet to say, this is my internal reporting system. These are my external registries, and this is the crosswalk I'm doing. Once you do that pre-work, I would say then please, contact us, contact me to start with, and then let's kind of figure out in your current state, what is your process for data submission? How are you doing it? And then, again, you're more than happy to consult with one of my RNs also to understand how do I make it better. So there are many ways. One is you can have a consultancy with the SMCH IS team. If your data is going outside of Packard, you can always talk to RedCap team. So again, Evie is here to represent the TDS team. If you think by getting the data into RedCap is one way for you to get the data out, RedCap can also facilitate that. So you have a couple of options. Cassie, I see you raised your hand. Do you want to comment, please?
Yes, I have worked on a lot of different registries in my time. I've been at Packard a long time. First step a lot of times is people haven't even thought away from manual. So they haven't thought about what fields are discretely documented and can be easily pulled over utilizing a report or an integration. The second part is understanding our internal flow. So just to give you an example from VPS, everyone is exploring large language models, everyone exploring what else can we do to pull this data out. One of the things that we're not great at Packard, it might be a surprise to you, is we're not great outside of the NICU of having very strong problem lists. And for VPS, we really need a lot of information surrounding the diagnosis to make sure that the problems or the diagnosis we're putting in are accurate. Without a validated problem list, that is something that still continues to take these nursing brains that are reading all of your notes and trying to understand your diagnosis. There's still that translation piece. So there's the things that are like straightforward. I can pull demographics, I can pull lab values, I can pull, in some cases, vital signs. But there may be things that still really require the brain, that is still a human brain at this point, to abstract. So there might be in your registry some pull forward that you don't have to do. There's no reason to do that manual stuff. And that really does free up the time, if you have someone doing the abstraction, to do the stuff that takes the brain. So it's also, it might be hybrid. We might not be able to get it to a fully automated process. There still is that translation that we find necessary for VPS.
Thank you, Cassie. I hope that was helpful, Dr. Reddy.
Yes, thank you.
Mm-hmm. Any other questions? Thank you. I see a comment from Jean to all of us. When in doubt, a consultation meeting with Gauri and the registry team could be a helpful starting point to evaluate if and how manual effort can be minimized for registry participation. Absolutely. Thank you, Jean.
As an abstractor, you really this is the stuff that makes you feel fulfilled, right? It's not putting in a vital sign number. It's making sure that what you're putting in is used for improvement. And so we are definitely here. Gauri, obviously, as a leader, is here to help. But we, as quality specialists, are here to talk to your abstractors, too, because we speak the same language, and we'd love to make their work more meaningful.
Perfect. Thank you all so much. This was a wonderful presentation. This will be recorded and posted on our website, as well as our YouTube channel, so you can reference it and come back to it. I think what has really come out of the Q&A, as well as the summary of discussion, is how important it is to engage with you and your team, Gauri, and just come to an understanding of what you hope to accomplish. And as Jean kind of really put it best, just submit a consultation and you can go from there. So can't recommend that enough, and can't thank you and the team so just for the time. So thanks for all the work you put into this seminar. Really was
Thank you again. Thank you for having us. Bye-bye.
our
Thank
pleasure.
you.
Have a great day, everybody.
Yeah, bye-bye.